Thank you, Professor Kirti, for kind introduction. And I'm very excited to hear the discussion on 45s. In fact, that should be one of our carry home of this workshop. Tomorrow afternoon, when you leave this place, all should be clear. What is to be fortified, how to be fortified, what is to be given, how long is to be given. I'm raising one more question. If you don't get answer, come back to me tomorrow, I'll give you the answer. And I'm raising the question, is this? Suppose the HMF is not available. You don't have access to it. Either because of availability or because of the cost, what will you do? You being an Indian, I always will say that, you should have your ready solutions. So how would you customize that? And that is what probably she was trying to hint at, that how we create our own HMF. So hope you discuss. I'm available tomorrow. Don't go without knowing how would you make your own HMF. And I'm giving an experience that once I had a case of galactosemia. I'm talking long back, maybe 40 years back. There was no galactose-free milk available. And what to do? Their issue came of exploration. We explored and gave a milk to our baby, and I followed that baby till 1 year in Mumbai. And we explored, we found out the galactose-free food and created milk from that. It was mushroom. Mushroom and peanut, they have a very low content of galactose, and I could give it. Baby lived as long as I followed. So what I'm trying to say is, Indianize your thought processes. Whatever that's very good to know, adjusted, targeted. Well, does the facility available? If it is available, 100%, customize. Okay, coming to my task. Sorry, I'll be coming in between your lunch and this, so I'll try to be fast. But it is very relevant. A lot of questions were raised. Osteocalcium, when to give, how to give. And again, I'll say, either you have a tall people like Professor Ashok, or you have a shorter people like Girish Gupta. Choice is yours. So if you have a metabolic disease, you produce Girish Gupta. If you do not have a metabolic disease, you produce Professor Ashok. Choice is yours. So with the starting statement, this is a common scenario in an ICU. You have a 30 days old ELB that you on some nutrition, on ventilation, not being able to extubate, and here's a shocker for you. And this is live, the actual from the SGPGI. And this shocker we got. A fracture. And if you don't diagnose at the time of entry, parents will blame you. After haddi tod di bache. Fragility fracture. It's a real case in Lucknow. So be mindful of metabolic bone disease. That's what I want to say. Not that we only talk of ventilation, echo, everything else is required. As he said, silent killers. We just heard this word, silent disease, metabolic diseases, silent. I will emphasize right here, a tall human being is required. And why he or she is required? If person is tall, his or her organs would be larger. If a female is tall, her uterus would be larger. When she conceives, she will have a larger baby inside her. While a smaller female conceives, the house is small, the tenant has to be small. You cannot produce a large baby with a small uterus and a small size female. Therefore, it is essential that you have a large size female, large uterus, large inhabitant of the uterus, and a better next generation of India. So that is why metabolic disease of immaturity must be prevented at all costs. Hope I made my talk clear. Whether evidence or no evidence. And why there is no evidence, I also speak here. Long back, maybe 30 years back, I was invited in one of the hospitals in Pune, and I was made to talk on metabolic bone disease. Nobody was interested in listening to this. They only listen to talk which are more fancy talk. Because it brings in money. It brings attraction. But how many times you've heard metabolic bone disease talk? So I'm trying to emphasize that please pay heed. There will be some bottom line and the end. Please try to practice. Well, let me also give a little story to correct. This time will give me 2 minutes extra. I started my career post DM in Mumbai with first research project to my fellow, to my MD student. And when I gave the research project to my MD student, her name was Dr. Shushmita. I said, dear Shushmita, I'm giving a gold medal topic at the time of allocation of topic. And with Almighty's blessing, she won the gold medal award in National Conference of NNF in CMC Law. Osteopenia we discussed. We research on osteopenia. We challenge osteocalcium. I will dwell further, but just making osteocalcium, highlighting that where are the drawbacks in this. Well, coming to the RDAs and the requirements, again, I will be very fast on the recommendations and tables. If you want to take a short, please take it, because I would like to give messages. These are the requirements of calcium and phosphorus for a preterm baby, 120 to 150, 60 to 120, and 400 to 800. Why I put my slides differently? I don't put studies. For the simple reason, there will be too much of variation. 100 to 250 milligram per kg per day for calcium, and half of it for phosphorus. Now, what do you choose? Should you not take a via media? We are looking for a practice point. If I'm discussing at a postgraduate discussion, general club, it's fine. But here people would like what we should give. So please choose a figure which is middle figure. And again, my statement would be customized. That is to what to start with. Monitor your patient. If your patient wants more, give more. If patient wants less, give less. But there has to be some starting point. So please remember that. And then here I've given analysis of various milk, human milk, cow's milk, including from HMFs. Pick up whatever suits you, whatever is affordable. In fact, it's worthwhile. I'm just diverting by making a statement. We must analyze animal milks too, as it was just meant donkey's milk. There's nothing to laugh about. It is good. Camel milk is good. Goat's milk is good. So we must analyze other animal milk also for their composition, because all are not as lucky as we are sitting here. There are some tribals. I was working in Andamans. I found wild boar's milk is being used. So be an Indian. You should be trained and practice. You should be able to practice in all walks of life, in all extremes, whatever is feasible. So these are some milks. See whatever best suits you. So what I'm giving a bottom line, think of RDA and find out what is the nutritional gap in your patient from the feed which you are giving. And to bridge that gap, whatever is available. That's the answer. So nutritional gap has to minimize with whatever is available. Now, another thing which I want to emphasize is calcium and phosphorus homeostasis. What I mean by this, that in the body, in the serum, calcium and phosphorus have to maintain this ratio in term and in preterm. All right. So a little more in preterm as compared to term. So the applied statement here is that when we give a substance, an element, it would build that element. Suppose I give calcium. Now it will build up calcium. Now it has to be in the ratio which I have mentioned. So it is crossing that ratio. So you might be giving calcium, but this calcium would not be retained by the body. Body would throw it out. So there will be calcium. If I give just calcium, osteocalcium for that matter, there will be hypercalcemia, there will be calciuria, and if you continue to give it, there will be nephrocalcemia. So be mindful. So don't give one, give both if you have to. Give calcium and phosphorus together and pick up whichever preparation you have in the market. So supplement both calcium and phosphorus together and maintain a ratio of 2:1. That's very, very crucial. Now, a little bit of a theory. Normally, I don't talk about theory in the talks like this. But anyway, just very brief statement that we must know that a couple of hormones are involved in calcium and phosphorus metabolism: parathormone, calcitriol, and calcitonin. they are affecting all these three, but the bottom line I'm showing. The parathormone, which gets increased to maintain serum calcium normal. So if you parathormone giving would increase calcium, or parathormone will increase calcium, decrease phosphorus. Vitamin D would increase both of them, and while calcitonin will decrease calcium by depositing calcium in the bone. But this explains whether the action the kidney or the bone or the gut. Yeah. Now coming to the metabolic bone disease, which is the primary talk today. The basic concept is that as the babies are hungry or their bones are hungry, they have come without adequate calcium and phosphate stores. There are no accretion rates, and we do not supply them well. They will become hypomineralized. They will have a metabolic bone disease. So this is a general statement. More high risk, more demand, less supply, less supply. Now incidence, whatever, there are different publications, different ranges, and see how you can talk it. Exact ranges are there, 10 to 20%, 20 to 40%, 40 to 70%. What we have to understand that if we have a smaller baby, more is asked. There's a bottom. And hence, when the baby you are treating ALBW, right from day one, think of preventing osteopenia, because the incidence is much higher. And there are multiple variables. This is just here, the birth weight, gestation, treatment, disease, all will affect the incidence of osteopenia. So coming to metabolic bone disease, specifically looking at what causes, so I'm basically putting three categories for metabolic bone disease. They could be because of the less calcium deficiency, which is the largest chunk. There could be phosphorus deficiency, there could be vitamin D deficiency. So all would ultimately lead to a bone which is hypomineralized. And here I just put parathormone specifically in case of you find parathormone is increased. Parathormone would be increased when there is low calcium. So it is a state of a hypocalcemic osteopenia if you find PTH increased. But if or vitamin D, but if PTH is normal, then it is likely to be a phosphorus. So it's very simple, straightforward. Do parathormone, and if you find it is high, calcium or vitamin D, if it is normal, it is hypophosphatemia. Etometogenesis, very simple. Demand, supply, placenta, start thinking from placenta. Always remember placenta. It should be very close to the heart of India. Love placental information. A good placenta should be there. See that the time of bone growth, which is the last trimester, the fetus must remain inside with all the nutrients to the mother. And if they are not there, you will find there's a demand and supply gap of metabolic bone disease. So it's basically mineral deficiency, calcium and phosphorus. So it should not be that we give vitamin D and think that we have sorted out osteopenia. No. Calcium and phosphorus are primary treatment. Vitamin D is an additional. Now, just to say, don't think too much in details of this slide, metabolic bone disease. I'm just trying to put classifying them. The position could be prenatal. A lot of things are written here. They could be postnatal. A lot of things are demanding supply issues, vitamin D deficiency. But this block I would like to speak. Immobile. Don't let your baby to be immobile when you are ventilating. When you are keeping in the NICU. If you do not give physiotherapy, if you do not give massage, this baby shall develop osteopenia. Change practice from today if you are not doing. Usko hilao do. Tail munch. Exercises, I'll spend a little more time later on this. And the last block, lowermost, is drugs. Large number of drugs we commonly use, which are calcium-uric. Starting from caffeine. Larger dose, longer duration, more osteopenia. So be mindful of osteopenia when you are giving drugs. So it's multifactorial. Clinical features, n number of clinical features are there, but I would only like to emphasize two. You can have bones which are osteopenic and with fragility fractures. Don't get surprised. And the babies will find you get difficulty, you'll have a difficulty of getting them off ventilator because the chest wall is not rigid. It's highly compliant. and hence there will be failures of extraction. Think of always osteopenia when you have a failures of extraction. Laboratory investigation, large number of lists, but I would basically talk of phosphates, do alkaline phosphates. And here the abnormal figure is much higher than the normal what we have alkaline phosphates. Technically, we say 5 times of the normal of that particular lab should be the cutoff for to call it as an abnormal anemia. Okay. So maybe if it is more than say alkaline phosphates is say more than about 600, 700, then you think it is abnormal. But if it is 400, 500, it is normal for you. Keep that in mind. Okay. And think of serum parathyroid, as I just mentioned. Those people who are doing research projects or doing looking for some future projects, they should think of all the urinary markers of both metabolism, urinary calcium creatine ratio, phosphate creatine ratio, tubular reabsorption of phosphates, and serum calcium is not really pathognomonic. You may have a osteopenia with serum calcium nearly low. You don't get guided by imaging is very important. Here I would dwell a bit. Do X-ray chest, do radiogram or infantogram. Look at the bones, all bones. So whenever we are dealing with a case of intensive care, we always how the X-ray chest, how the lung looking, how the heart looking. Please do look at the bones in that X-ray chest itself. Ribs will be telling you that I am osteopenic. The humerus will be telling you that I am osteopenic. Look comprehensively. Though bone changes take little time to show these osteopenic effects. So around roughly 3 to 5 weeks. So on average, it may be a good idea to do a kilogram at around 4 weeks, but some plus minus. The gold standard for diagnosis for osteopenia would be DEXA, dual X-ray absorptiometry. Theoretically, we talk, but I wonder has anyone done a DEXA in newborns for diagnosis of osteopenia. So more for academic discussion, but in case if you are doing any research project, it should be done. Something which is bottom line is again close to my heart. Longitudinal quantitative ultrasound for measurement of speed of sound, SOS. I wanted to do a project long back in 1994 on this. It was almost through, but DGFMS suddenly said, FMR said, no, you can't do this. We will not give ultrasound. That was the end of my dream. We must look for non-invasive methods of diagnosing osteopenia. I suggest, recommend that people should be doing research on osteopenia and speed of sound. It is doable and you'll have a fair degree of accuracy. So do infantogram. The one X-ray just to get interest. All this is happening. Osteopenia, fracture. What is this? This is the periosteal reaction. You find it with this, it's one of the characteristics. Look for it. And if I give this as a preterm, who's 26 figure on prostaglandin, and I give a bone formation as a second layer of bone formation. Give me the diagnosis. Now anyone. Please see my condition, what stem I gave. You are right, sir. What stem I gave, a preterm. He is on PGE1, and then he's getting this after some use of the PGE1. There is a straight lead. I want DM students must be. Otherwise, I'm going to put this slide in the examination. So here it is a side effect of PGE. So keep that in mind. So it was just a diversion. So look for whenever you have a osteopenia, look at the shafts, look at the bone density, look at the periosteal reaction, look at the bony ends. You'll find there are findings. Because of the shortage of time, I removed lots of slides, but I wanted to show X-ray chest. And basically, I'm just telling you the X-ray chest. Look at the which junction? Costochondral junction. Right? When the infant walks, stop, or stands, the metaphysical ends they get widened. But for newborn, he's not going to stand and sit. But his rib is working every time. So his costochondral junctions are going to get widened. Look at that. Again, you will have a double lining for the ribs. Well, if the patient is not sick, and if you get a double lining like this in the chest, what is your diagnosis? Anyone? People from behind should speak. Am I clear? बच्चा टर्म बेबी है, चलो हमने एक एक्सरे चेस्ट लिया, उसके रिब पे ऐसे डबल लाइनिंग से आ रही हैं हर दिन, उसे नहीं है, टर्म है, शेकन बेबी. जब बच्चे को आपने इसलिए वही है तो आपको डबल लाइन मिलेगी. Keep that in mind. Okay, right. Now treatment. Stop and minimize precipitating drugs as we have discussed on the factors. Appropriate nutrition with appropriate RDAs. That should be kept in mind. And if that still problem persists, you should start giving therapeutic dosages of phosphate, start 10 milligrams per kg per day, and keep it upscaling every year till you have that adequate dosages. Likewise, start calcium 20 milligrams per kg per day and keep it upscaling every year. Select right calcium product with appropriate calcium and phosphorus. Please remember that. What award I got was for this reason, that the product which was chosen was calcium gluconate. Oh, sorry, osteocalcium. It doesn't have a right amount of calcium and phosphorus. And we proved that it produced osteopenia of premature. So choose a product which is the right amount of calcium and phosphate in a ratio of 2:1, and physical activity. I'll dwell more on physical activity as well. Treatment continues. When we are looking at the bone, it has an osteoid tissue. And osteoid tissue is made up of a collagen fibers. And in the collagen fibers, when you look at, there are small gaps in between. Collagen fiber coming from top, collagen fiber in the bottom. And there's a gap in between. We call them as holes. And these holes, the minerals get deposited. Okay, so calcium, phosphate, magnesium, etc. get deposited. You have a collagen here and collagen here, and in between, in the holes there is a deposition. And for synthesis of collagen, you need proteins. You need vitamin A. You need vitamin C. So when we are thinking of osteopenia prematurely, we should not just think of calcium and phosphate. So when you are treating osteopenia, think of adequacy of protein. Think of adequacy of vitamin A, C, and how long you give till get the radiological and biochemical parameters when they return to normal, at least till 2 to 3 months, or err on the side of giving longer than short. Effect of physical. Now, very conventionally, we are doing oil massage, do touch and manipulation. Now, there are various ways one does. I'll just show you the beneficial effects of physical therapy. Now, raise hands after seeing this slide that whatever circles I have created around physiotherapy, how many of you that this much can be the advantage in case of hospital as a result of it? So think about positioning, think about tactile stimulation, think about passive movement, play, oil massage, joint compression, and weight bearing. All is feasible, is being done. If you get this could itself be a result. How many times do you pay attention for physical therapy for osteopenia? Please start with prevention. We'll start again from our journey from the late pregnancy. So delay birth only to the term babies, appropriate intra-uterine nutrition, provide phosphate in TPN. The major problem in TPN is phosphate is not given, either it is not available or people don't know. I'm thankful to SGPGI, my faculty was, whether they were giving anything else or not, but phosphate was given for sure. Thank you very much. So know the product of phosphate. Okay. Oil massage in physical therapy. Early educate calcium, phosphate, vitamin D supplementation, minimal uses of drugs reducing hypocalcium and hypophosphatemia. We all should know this in practice. So it's a question of an attitude. We talked of initially placental centricity, then we talk of breast centricity. Now there should be an attitude of osteopenia prevention centricity. Even if there is an attitudinal change, you don't remember any detail today, my job is done. Now, I'm just showing 1 or 2 preparations. I'm not most up to date, but people like Dr. Akansha and all those who are working in the floor, they know which are the products available for IV. So phosphorus during PPI, hot phos is available, even the sodium compound is available. Cost not too much, but you should know that it is required. If it is required, you will produce, you will generate. And what I want to convey to all my younger colleagues, be a good theoretician is perfect. but analyze the therapeutic indices, what is available now. If you don't know those products, you can't write prescription of efficacy. You are becoming doctor only to write prescriptions. And if you can't write a drug which you want to write, then you are no good a doctor. You can become a doctor like me, just stop. Here I put some of the prescriptions. Calcium, phosphorus, vitamin D. I'm not biased for or against a company. The hard work is done again by my colleagues sitting here. So these are the products which are there in the market. And you see, out of all these products, how many of them calcium and phosphorus? Firstly, do they have or do they have in right proportion? See, only two products I can see, Phosphate D, 50 phosphorus is there, and calcium P, phosphorus. Others, no. You will still find people writing Shelcal. You will still find people writing osteocalcium. Don't do this blunder. I'm not for a product. I'm looking for a product where you say that it is both calcium and phosphorus in the ratio of 2:1. Am I clear? And here I also make that point which was raised, that how to give it and when to give it. Because normally, it requires a little larger volume of calcium phosphorus syrup. Say 15 ml has got this much amount. So maybe in that case, we have to start the supplementation, distribute over all feeds. Maybe 1 ml or 2 ml per feed, you will be able to adjust. But if you give 5 ml in a feed and the baby is taking 7 ml, you have given all your calcium and phosphorus, no nutrition, no other diet. So please take this into account. And even you will analyze something in the bottom, even which says about some HMS. Please remember this. Don't do this mistake after this class of not giving phosphorus. Product is your choice. Awareness. We should have a ready reference available in any way, whatever you carry, but this reference should be available to you. Now, role of AI. Earlier, I used to give a talk, and there was no talk of mine without apps on the smartphone. Now, it is smiling. Well, I'm changing. Yes, so now there'll be no talk of mine without AI mentioned. It's not that I'm an AI man, but I want my younger colleagues should know AI. You should embrace AI. You shouldn't be the followers of Americans. And we quote American study and say, very good word. I must quote SGPGI word, and American should quote it. When I was starting my NETSU 2022, the inaugural sessions were attended by people from 10 countries. And one of the person was Dr. Shu Lee from Canada. And he made a statement, Dr. Gupta, it seems, now rather than Indians coming to me, we have to come to Dehradun. No, it's not. Thank you, thank you. So this is not for me, this is for all of you. You are people of substance. It is your attitude which needs to be changed. Sooner you change your attitude, you will be an upright person. And if you do not change, you are the future leaders, who would run the country? All subservient? No. Please take lead. So all this, whatever you want to use, role of AI, but my caution, as I cautioned in the morning as well, AI is not foolproof. Double check, triple check, and then you do things. So be contemporary and don't get obsolete and extinct. My worry is this. I tell all my people that if you don't take that, embrace this at the moment, there is a risk of getting extinct. Counseling. There is no medical condition where you don't do specific. And osteopenia is no exception. Please make it as an integral part of your prescription writing. Counseling should be one of your blood of each prescription and of the practice of it. Do your own introspection till today. How many times you have written counseling as your last bullet in your prescription? There's another thing which I always say, that the last part of prescription bullet should be report SOS. Means you are transferring your responsibility to the patient's attendant. Otherwise, if aapne to bulaya nahi tha, main to aapke hisab se. So remember these things. Counseling should be the part, nutraceutical should be the part, and report SOS should be the part. So, found your skills of customized condition-specific counseling have an excellence. Do 2 types of formatting of yours. One is a general counseling, and second one is a focused counseling for that condition and for that baby. You will be, सारी दुनिया आपकी भक्त हो जाए. Remember this golden state. Research questions. So I've already mentioned, but I thought I will put 1 or 2 points here. And maybe we should look forward to doing some role of speed of sound in diagnosis of osteopenia prematurity. Institute can think of taking a project and follow-up studies in cases of osteopenia prematurity. So my bottom line is, be a scientist. Find your own solutions and innovations to your problems. Don't interpolate कि उसका data ये था, उसके लिए subjects थोड़ी थे, ये तो हमारे subject. Problem आपकी है ना. हर बार आप जब रिसर्च करते हो तो कहते हो सारा डेटा तो है, लेकिन हमारी पॉपुलेशन का डेटा नहीं, इसलिए हम ये स्टडी कर रहे हैं. तो स्टडी करने के लिए तो आप वो करते हो, अप्लाई करने के लिए नहीं करते. Why? To what a dichotomy in the approach. Don't be such a person. To conclude, ladies and gentlemen, calcium and phosphate deficiency should be remembered together. Do a timely screening. X-ray, alkaline phosphate is raised. Do even X-rays. Look at the parathormone. It will give you direction. When you're giving TPN, don't forget phosphate. Human milk alone is insufficient, as we have discussed. So there are nutritional gaps when we give human milk alone. You have to give supplements to bridge those gaps. Earlier, appropriate phosphate and calcium supplementation is must. And how long it should be continued? At least till baby is more than 2.5 kg. Really, I amuse. I feel very interested when we just talk of supplementation and we talk gestation age driven or age driven supplementation. So we are analyzing weight. But our supplementation indication should include weight criteria as well when we are talking. But we are talking only gestation related criteria. So there is a scope to improve things in practical thinking, practical approach. Why we don't talk this? Because the published literature is only gestation. Ensure the chosen compound which has adequate phosphate. The actual chemical compound is bone. It is calcium hydroxyapatite, bone calcium. Concurrent prescription in bone building should be protein, vitamin C and D. Just for example, जब हम blood की बात करते हैं, तो कहते हैं हाँ भी blood दे दिया ठीक है, erythropoietin दिया वो भी दिया, building blocks दिए क्या उसके? Which means proteins, iron, folic acid, B12 आपने दिया नहीं दिया, वो नहीं दिया. So don't be narrow-minded. It means you are not looking comprehensively at your prescription. Ensure physical activity with due care and diligence. Do it regularly. Avoid premature birth in all recipient factors of MBD and ensure tall Indians with future generation with difference. Thank you very much for that.